disease is a complex autoimmune disorder. Understanding about the pathogenesis of thyroid eye disease is evolving. We all know that there are development of antibodies against self-antigens in thyroid eye disease, which attacks the orbital tissues, and it can either cause a fatty disease or a fibrotic disease. We know that TED presents from a very mild inactive disease with a mild lid retraction to a very severe debilitating disease with this dysthyroid optic neuropathy and exposure keratopathy. So what do we do now? We treat based on the clinical activity scoring, visa scoring, and grade them according to the UGOGO guidelines. And we treat them with steroids, immunosuppressants, radiotherapy, and few of the targeted therapies which are available. So what is lacking? We treat after the disease is well established in the eye. And most of the audience here and the teachers here would agree that management of an active thyroid eye disease is very challenging. So what could be ideal? Identify the patients who will probably develop an active disease and treat them before they develop a very severe disease would be an ideal thing. So how to find the patients who will develop an active disease? To look for biomarkers. So biomarkers can be seen in various body fluids and tissues, but tears is ideal as it is in direct contact with the eye. The lacrimal glands are also affected, and it is easy to procure tears, and it is non-invasive. So with this background, I did some literature search, and I found that there were a lot of work done on tear biomarkers in thyroid eye disease. One of an interesting meta-analysis in Biomolecular Journal was the authors had compiled the work done on tear biomarkers, and majority of the authors have found those inflammatory cytokines to be increased in thyroid eye disease. So with this background, and since there were no Indian studies done, I aimed to look for significant markers in tears in thyroid eye disease. It was a small pilot prospective study after ethics clearance. We diagnosed TED based on Gorman and Bartley's criteria. Activity grading was done by visa scoring, and severity was done by UGOGO guidelines. The tear samples were collected from 2 tertiary care centers with Schirmer strip. The protocols were followed meticulously in both the centers. The samples were stored in -90-degree refrigerator, and the analysis was done in a tertiary care center lab. We collected samples from healthy controls, patients with thyroid eye disease, and patients with thyroid disorder but no eye disease. We excluded patients with other systemic and ocular disorders and not willing for the study. We performed multiplex ELISA. Our panel had these inflammatory markers. And in our study, we had 19 patients with thyroid eye disease, 11 patients with thyroid disorder but no eye disease, 13 healthy controls. Among the patients with TED, we had 11 active patients and 8 inactive patients. This was the gross result of our study. We found most of the inflammatory cytokines were elevated in thyroid eye disease compared to healthy controls and the no TED group. However, we noted a statistically significant increase in interleukin 6 and interleukin 10. We also noticed the activity had a strong risk factor for an increase in IOP, and IOP was directly related to dysthyroid optic neuropathy. Interestingly, in literature, we did find that antibodies against interleukin 6 receptors were being used to treat patients with active TED. Randomized control trials is being done on that. And we did find that there are so many other targeted therapies for such inflammatory biomarkers. So in future, biomarker detection can give clue to as in to say that who could succumb to the disease, and looking for potential markers and treating them with specific antagonists earlier before the visa scoring of 4 could probably help us to avoid high dose of steroids. And to conclude, tear biomarkers can be a promising clue to diagnose patients at risk of developing sight-threatening complications. I would like to acknowledge the people who helped through my journey. Thank you.
It's not from the paper, but related to the paper. They said that there is some launch of biomarkers. Tear. Is it same?
Huh?
In the conference, there is some launch of tear biomarkers. Is it the same?
Tear biomarkers panel has been in the trade you're telling, ma'am? Yes,
the launching
is, yeah, that
kit
is
I am
for
asking.
dry eye. So they have launched a panel for dry eye to detect the inflammatory markers for dry eye. We are working with the same lab, and this is in thyroid eye disease.
Good presentation. Just two quick questions. Was there any correlation between your findings on the biomarkers and the presence of autoantibodies?
Sir, I actually did not check for autoantibodies in this particular study, sir.
Right.
That would have
And
added
what is
more
your routine
information.
practice? Is it TRAB, TSI, or both?
Sir, actually the thyroid function test T3, free T3, free T4, TSH were done for most of the patients. Many of the endocrinologists still do not advocate or write the antibodies in our setup, and many labs also do not have that antibody. I did not have luxury of doing the test myself.
Right.
I was only able to do this.
So at least don't leave it to the endocrinologist. You ophthalmologists should be ordering these antibodies and order both the antibodies. Second quick question is, where do you plan to take it from here?
Sir, I think this is just a small start, but I think I have a long way to go. My hypothesis is we are treating once the activity scoring is after 4. So if we could revise the thought process and start looking in or following up the patients who even have a mild thyroid eye disease by looking in for markers like this in tears, and if the markers are significantly raised, then even before the visa scoring of 4, we can probably treat them with the specific targets, because this panel gives which one is raised also. That is my hypothesis. I do not know how it would work, but this is my hypothesis.
Great. I think that holds a lot of hope. Thank you very much.